Hello, everybody. A warm welcome to this UCARE LevelUp program for understanding cold urticaria from diagnosis to management. I am Dr. Indrashis Podder. I am working at the UCARE Center, College of Medicine and Sagar Datta Hospital, Kolkata, India. So today we have a fascinating line of speakers who have been working extensively on this very interesting form of urticaria, which is cold urticaria. And as we go forward, we'll learn from them the various intricacies. So I'll be your moderator, of course, and the faculties we have Dr. Angèle Soria, who is working at the UK Center at Sorbonne University at Paris, France. She is also the head of the task force on urticaria from the French Society of Dermatology, and she is also working with several patient associations. Then up next, we have Dr. Mojca, who she is working at the UK at the University Clinic of Respiratory Allergic Diseases at Slovenia. And last but not the least, we have Dr. Hanna. She is working at the UCARE at the Charité University in Berlin. And she, of course, all of them are seeing a lot of patients with cold urticaria and they have worked extensively. So we are going to look forward when they share their expertise with us on this difficult topic. So we have a lot of registrations, you can see, and almost 56. So a lot of countries and a lot of people have registered for this webinar. So it's truly a global webinar in that sense. So we will just try to explore the classification and pathophysiology of cold urticaria, which will be dealt with by Dr. Angèle. Then the clinical presentation and diagnostic approaches will be by Dr. Mojca. Now, she is not here with us because of some unwanted some circumstances. So we will be playing her recorded lecture. And finally, Dr. Hanna will be sharing with us some of the differential diagnoses and how to differentiate them from cold urticaria. So this is our agenda for today. And as we have already discussed, there will be talks first. And I'd request all our viewers to please put in your questions in the question box. When you're viewing, there will be a chat box at the end. So please type in your questions with your name and your place so that we can discuss all the questions at the end. So we will have all these presentations one by one. And at the end, we will take up your questions and I'll try to discuss as many questions as possible, so that you can get the expert opinion on those questions. So please buckle up and put forward your questions in the chat box. So we have this CME accreditation 1 point, but to get this CME accreditation, you need to actually fill up this form, which is at the end of the webinar. So please complete the feedback form at the end of the webinar to receive this accreditation. So this is important. So stay till the end and fill up this feedback form. Stay connected with us. The UCARE, it's a evolving and a growing network, as you can see. So scan this and you will be able to get to the details of our activities. So link to us on social media. There is a newsletter also. We have a regular newsletter also. So you can subscribe to that. You can learn about the latest advances in urticaria. Next UCARE meeting is again on another very interesting form of inducible urticaria, that's cholinergic urticaria. So that will be on September 11th. So after this, register for that meeting also, because that is going to be a very interesting meeting. You can see speakers from all over the world, Japan, Austria, Australia, and Jason, our good friend, will be moderating this session. So do register for this webinar. So this is the QR code. You will of course get the registration details by mail also. So thank you from my end, and let's get started for today's webinar. So it is my pleasure to invite Dr. Angèle to start with the proceedings. She will be discussing about the classification and pathophysiology and genetics of cold urticaria. Dr. Angèle, it's all yours. Thank you.
Thank you very much. Hi, everyone. Thank you for this invitation. I talk about classification and pathophysiology and genetics about cold urticaria. My disclosure. The content of this presentation: first, classification, pathophysiology, and genetics. The classification of cold urticaria syndrome at the beginning of the history of the big entity of cold urticaria syndromes is classified between two different types: acquired cold urticaria syndrome or familial cold urticaria syndrome, if you have an history of familial cold urticaria. As you can see in this publication, Wanderer in 1986, there is a clinical classification of cold urticaria. Cold urticaria was included in this cold urticaria syndrome, and it was defined by acquired cold urticaria syndrome with a non-familial heterogeneous disorders characterized by urticaria, angioedema, and occasionally symptoms of hypotension after cold exposure. And as you can see here in this first classification, there is a primary cold urticaria called to idiopathic versus secondary with some triggers such as infections, malignancy, drug food, others. But the causal links often weak or unproven. And initially, familial cold urticaria syndromes were included in this cold urticaria syndrome, but now it's not the case. Because, as you know, there is a new classification for many years of chronic urticaria with spontaneous chronic urticaria and with chronic inducible urticaria. Both conditions may occur in the same patient. And cold urticaria is a part of chronic is a type of chronic inducible urticaria, and it's a type of chronic urticaria. Cold urticaria was first described in 1792 with typical cases recorded, and patient have, as in this picture, it's one of my patients after swimming in sea, and she has eyes developed after exposure to cold stimuli, the swimming in this case, and sometimes angioedema triggered by cold environment, with cold weather, cold water, or cold object in the contact. And in some patients, thermic differential above threshold temperature and can occur of any age. The severity, there is a particular form which called anaphylaxis with pathophysiologic shock, and the prognosis of this form may be life-threatening. And concerning the actual classification of cold urticaria, it's according to the cold stimulation test, CEST, and there is two types of cold stimulation tests, but we will see in detail this in other talks. If you have a positive cold stimulation test, you are in typical cold urticaria forms. If you have a negative or atypical response to cold stimulation test or atypical urticaria, you are in atypical cold urticaria forms. But in this classification, the familial cold urticaria syndrome are excluded totally. Here you have a typical cold urticaria with wheals or angioedema appears on rearming, as you can see in the picture, within 1 hour confirmed by cold stimulation test. Here ice cube test results, and here a TOM test device. Which explore cold urticaria between 4 and 27 degrees. And concerning atypical cold urticaria and CST response, you have different form of atypical response to CST. You have atypical CST with a typical urticaria response, which called the systemic atypical cold urticaria. Typical response to CST with an atypical urticaria response. These patients have localized cold urticaria only, for example, on the arm, or delayed cold urticaria 2 hours or more after the contact with the cold. Or some patients, but very rare, are atypical CST with atypical urticaria response. These patients have urticaria in special condition. For example, there is a cold-induced cholinergic urticaria. The patient describes there's very rare case in the literature. I have no see this type of patient. We are cold urticaria precipitated by exercise in cold environment, for example, or the cold-dependent demographism with association with demographism occurred in cold skin. And these variants are rare and in many cases insufficiently well characterized, but they They are in the classification. There is this classification had been published by the cold CEST steering committees in 2021, as you can see in the year of the publication. And I present you for the clinical practice the severity classification of cold urticaria. It's a Wanderer classification published in 1986 because during cold urticaria, the cold anaphylaxis can induce death, and it's very important in clinical practice to know patient with potential severe cold urticaria. As you can see in this first publication of Wanderer, there is a classification in 3 types of severity: type 1, type 2, type 3. And as you can see here in this diagram, we have published French guideline about cold urticaria management, and we have classified the cold urticaria with this severity classification with type 1. When the patient has only localized reaction to the cold, like a contact urticaria reaction localized to the contact with the cold, sometime angioedema, it's possibly. Type 2, the patient have systemic reaction, but without hypotension. He has 1 or more episodes of generalized urticaria, angioedema, but without hypotension. And the type 3, very severe systemic reaction. The patient have 1 or more episodes of generalized urticaria, plus or angioedema, but with association with hypotension or shock. And this patient, as you can see in the Wanderer publication, represent more than 1/3 of the patient initially described, and it's not so rare. And to my opinion, important when you see a patient with cold urticaria, to have at the beginning of the diagnosis to ask him if you have vasoplesic shock, if you have any problem with cold beverage or cold food, for example, and you can very easily have a practical classification of a simple cold urticaria with only urticaria on the contact with urticaria, and type 2 and type 3 with cold-induced anaphylaxis with a very severe form of cold urticaria, with a potentially systemic reaction, potentially life-threatening form, and in the vast majority of these cases, the vasoplesic shock occurs when the body is immersed in water, in cold water, or with a big differential of temperature between the weather and the water during swimming. Concerning pathophysiology of cold urticaria, it's not well understood. There is many concepts. The major concept is the type 1 autoimmunity with autoallergy concept. There is, as you can see in this graph of the publication of Marcus Maurer, the cold induce autoantigen formation triggering IgE response. And some experiments with positive passive transfer have shown that cold urticaria can be induced in healthy patients by intradermal injection of serum for patients with cold urticaria, and the neutralization of these IgE prevent urticaria reaction, suggesting the involvement of the IgE pathway and during cold urticaria, and the possibility of autoantigen would form de novo with a specific temperature, and this autoantigen will be detected by IgE bound to skin mast cell and activation of mast cell and basophil. There is another immunologic mechanism supposed, the type 2B autoimmunity, such as in other subtype of chronic urticaria, but there is very few reports about this type of autoimmunity with IgG and IgM anti-IgE antibodies found in some patients. And anti-Fc epsilon R1 alpha antibodies are rarely detected in some patients. Here you have a table of the Cold Steering Committee publication with a summary of indirect evidence of IgE-mediated autoimmunity during cold urticaria. There is many but more argument for the IgE autoimmunity implication during cold urticaria, and some reports are against this hypothesis. If you show the skin histology, a skin biopsy during a flare of cold urticaria after skin testing, for example, there is in the literature there is variable infiltrates. You can have neutrophils, eosinophils. One study found an alpha-1 anti-chymotrypsin deficiency with hypothesis that there is regulation problem by a neutrophil pathway with poor control of protease, but sometimes in some publication infiltrates are totally absent. Maybe due to the timeline of scan biopsy after the beginning of the eyes, maybe. Concerning cytokine, a study report sequential regional skin biopsy from cold urticaria patient with early upregulation of endothelial TNF-alpha and interleukin-3 expression within 30 minutes after an ice cube test. Cryoglobulins show in less than 1% of the patient with cold urticaria. Precipitating cold can activate complement, some fraction of complement, but the role of cryoglobulins in cold urticaria is unclear because it's very rare during cold urticaria, and we know that the role is not via IgE cryoprecipitation. Concerning the genetics, there is no gene during cold urticaria, but you have a differential diagnosis, the cryopyrinopathy or cryopyrin-associated periodic syndrome, CAPS, which at the beginning of the story of cold urticaria syndrome, as I can show you on the first slide, was included in cold urticaria, but now it's it's a differential diagnosis. It's very quickly, it's an autoinflammatory disease, a group of diseases with genetic autosomal dominant mutation caused by heterogeneous gain of function mutation of the NLRP3 gene encoding cryopyrin. It's a very rare syndrome, 3 to 500 cases worldwide, and the NLRP3 gene, this gain of function of this the mutation with gain of function provoke an hyperactivation of the NLRP3 inflammasome, led to excessive production of interleukin-1 beta with quasi-permanent inflammation in this patient and inflammatory syndrome. And there is many entities, clinical entities with, familial cold urticaria, Bonnekoh syndrome, chronic infantile neurological cutaneous and articular syndrome, which is called CINCA, the rarest and the most severe form. But in practice, it's the same spectrum now. The familial cold urticaria and the Bonnekoh syndrome are similar, with often familial form. CINCA mainly affected isolated patient, and there is another form. But cold urticaria differ from CAPS because when you have a patient with cold urticaria, the feature immediate after cold contact, itchy wells post-cold exposure, resolving quickly, and in most of the cases, no systemic symptoms, exceptionally in severe cold urticaria with anaphylaxis. During CAPS, skin lesions are not itching, not papular. There are flat weeds or erythematous patches, and skin lesions develop with a dilate after cold exposure, and the patient have other systemic symptoms, fever, it's a red flag, arthralgia, asthenia, for example. The cold stimulation test do not provoke CAPS, because the CAPS requires generalized cold exposure of the body for have the lesions. Here, what kind of genetic testing in CAPS and cold urticaria? Cold urticaria, there is no genetic research in routine diagnosis, but for the CAPS, there is a molecular genetic testing of the SIIS1 and LRP3 gene, but all the mutations are not all known today, and mutation remain undetected in some patients. But you must do the molecular genetic testing if you have atypical cold urticaria in a patient during childhood with elevated CRP and with fever, with another systemic symptoms, and you must ask to your patient if there is another clinical manifestation, musculoskeletal symptoms, sensorineural hearing loss, for example, chronic aseptic meningitis. It's very important because our diagnostic is essential in this patient, because there is a specific inhibitor with interleukin-1 blockade therapy to prevent chronic inflammation in this patient, because there is a risk of renal involvement with amyloidosis AA in 2 to 4% of cases. Other genetic syndrome with cold-induced urticaria eruption are described in some families. The factor 12 associated cold inflammatory syndrome due to factor 12 gene mutation in infancy with negative high-stage cube, but symptom last after cold exposure. The plate syndrome with phospholipase C-gamma 2 associated deficiency and immune dysregulation caused by PLGG2 deletions. It's a neonatal onset of cold wheals, but there is not only cold wheals, there is atopy, granulomatous rash, there is autoimmune thyroiditis, many immune defect with switch memory B cell, with antinuclear antibodies, with senescent pulmonary infection and common viral immunodeficiency. In this patient, as you can see in the publication of New England, which described a family with this plate syndrome, the ice cube test is negative, but you have a positive evaporating cooling test with ethanol, as you can see in the picture, and it's very different because you have many other immunological manifestation in this patient, and normally these patients are diagnosed during childhood. Some key message for finish. The classification of cold urticaria is based on cold stimulation test with typical and atypical cold urticaria. It's important to have a severity classification due to the severe form of cold induces anaphylaxis with a risk of threat to life. As I can see, the pathophysiology of cold urticaria is not known very well, with the role of immune system, with autoallergy concept is predominant, but maybe other mechanisms are involved. And the genetic factor plays in the significant role in the CAPS, not in the cold urticaria with familial cases. And it's important to diagnose it during mainly in the infancy to treat it specifically. Thank you for your attention.
Thank you, Dr. Angel, for your very nice and lucid presentation. So now we next on to our next topic, which will be by Dr. Mojca. But as we have discussed that she is not here live, so we will be playing her recorded lecture. The lecture is on clinical presentation and diagnostic approach and treatment for cold urticaria. So I'd request again our viewers to please post your questions in the chat box. And I'd request our team to please play her video recorded lecture. Thank you.
Hi, I will speak about clinical aspects of cold urticaria. It is characterized by wheals, angioedema, or both, appearing rapidly in response to cooling. The severity can range from localized reactions to serious life-threatening responses. Cold urticaria is diagnosed clinically. Wheals are sharply circumscribed, superficial swellings that vary in size and shape and are typically itchy. Angioedema, on the other hand, presents as deeper erythematous or skin-colored swellings. In the cold CE study, median duration of wheals was 30 minutes and angioedema 45 minutes. In the same study, the most common trigger of typical cold urticaria was cold air, followed by full cold water immersion. Other possible triggers are listed in the table. It is important to note that cold urticaria and systemic reactions can also be triggered during surgery by low ambient temperatures or cold parenteral solutions. Extensive cold exposure, such as swimming in cold water, can provoke anaphylaxis. In the cold CE study, it was defined as involvement of the skin plus one other organ system, and it was diagnosed in 37% of typical cold urticaria patients. Defining cold-induced anaphylaxis can be challenging. For example, symptoms like respiratory distress in asthma patients may result from an asthma exacerbation and not anaphylaxis. Additionally, gastrointestinal discomfort from cold food may stem from mucosal cooling rather than anaphylaxis. A detailed history and standard local cold stimulation testing are essential for diagnosing cold urticaria, as no biomarkers are currently available. According to the latest International Urticaria Guideline, laboratory tests are recommended only as an extended workup if symptoms are atypical, if there's a suspicion of an associated systemic disease, or to exclude differential diagnoses. And Dr. Bonnekoh will discuss them. Local cold stimulation testing is performed on the volar forearm using an ice cube in a non-latex glove and temp test if available for 5 minutes. To conduct the test, tie the glove's fingers, place the ice cube with a small amount of water and let it partially melt before applying it to the forearm, and then observe for additional 10 minutes. Typical cold urticaria is diagnosed when a wheal appears within 10 minutes after 5 minutes of stimulation. If positive, shorter stimulation times, usually 30 seconds to 4 minutes, are tested to determine the stimulation time threshold. Using 2 ice cubes can speed up testing. As you can see on the left photo, one can be tied to the forearm for 5 minutes and the other one is used for shorter times. The ice cube test has up to 90% sensitivity and 100% specificity, but it lacks standardization. There are variations in ice cube size and temperature. The temp test provides standardized results, which are essential for retesting patients to assess therapy response or for multicenter studies. It can be used to confirm typical cold urticaria, to measure the temperature threshold, which is the highest temperature inducing a positive reaction, and with its 2 mm white metal element, allows quantitative assessment of wheal diameters. In the cold CE study, 75% of patients had positive local cold stimulation testing. The median stimulation threshold was 300 seconds, and the median temperature threshold was 18 degrees Celsius. Among patients with both tests done, 81% tested positive on both the ice cube and temp test, 17% tested positive only on the ice cube, and a small percentage tested positive only on the temp test. The cold CE study also showed that patients with shorter stimulation time thresholds had higher temperature thresholds and larger wheels in the temp test. This suggests that those who respond more quickly to a trigger also respond at higher temperatures and with more severe skin reactions. Negative standard local cold stimulation testing may indicate atypical cold urticaria, which is very poorly defined. It involves an absent or non-classical response to a 5-minute stimulation on the forearm, as I just described. And you may see wheals appearing outside the tested area or later than the 10-minute observation period. The prevalence of atypical cold urticaria is unknown. However, negative standard cold stimulation testing has been associated with spontaneous wheals, raising the question of whether patients have cold exacerbated CSU rather than cold urticaria. Additionally, patients with negative testing have recently been found to have a lower occurrence of cold-induced anaphylaxis. If cold stimulation testing is negative, the history should be reassessed and adjusted cold stimulation testing may be performed. This slide outlines various tests for atypical cold urticaria that were reported in case reports and case studies. These include prolonged ice cube application, cold pack test, and hand immersion test, as well as more specific tests like the cold room exposure and evaporative cooling tests. The methods are typically selected based on the patient history. This table shows different types of atypical cold urticaria that were also only described in case reports and small case studies. I don't have the time to go into details, but I will highlight a few examples in the following slides. Sometimes patients report whealing only in specific areas, and you can try to confirm this by applying an ice cube to such locations. Sometimes you may see wheals appear next to the area stimulated by the ice cube, but they are lacking on the stimulated area, which remains negative. You may also observe multiple papules appearing at the cold stimulation site instead of a large confluent wheals as usually seen. This has been described as cholinergic-like contact urticaria, but it remains unclear whether this is actually a type of typical cold urticaria. Early identification of high-risk individuals is critical before a potentially fatal reaction occurs. Swelling of the tongue or pharynx is a key high-risk feature. Patients with a history of anaphylaxis were also found to have a higher frequency of generalized wheals, angioedema, itchy earlobes, we don't know the reason for that, and longer disease duration. High-risk patients also have shorter stimulation time thresholds. In this photo, you can see that it was 30 seconds. They can also have higher temperature thresholds. In this photo, I believe it was around 27 degrees Celsius. They also have larger wheel diameters. Remember, the electrode of the temp test measures 2 millimeters, and on this photo you can see that the wheel width is around 13 millimeters. And in provocation testing, you can see also wheeling extending beyond the stimulated area, but this is not a very common observation. Management of cold urticaria includes avoiding cold triggers, education on high-risk activities, using epinephrine for cold-induced anaphylaxis, monitoring disease activity, and providing pharmacologic treatment. Patients should be instructed to avoid cold triggers and educated about high-risk activities. They should avoid cold foods and beverages if not tolerated, and they should exercise caution with cold water immersion. Anesthesia and surgery teams should maintain normothermia with blankets room temperature above 21 degrees Celsius and pre-warm intravenous fluids while having epinephrine prepared in advance. Special care is also needed with cold parenteral medications. Epinephrine is the first-line treatment for cold-induced anaphylaxis, and patients should be educated on how to recognize and manage anaphylaxis. Intramuscular epinephrine should be administered immediately. High-risk patients should be prescribed an epinephrine autoinjector and educated on when and how to use it. The COLD-CE study found that less than 10% of patients actually received epinephrine during anaphylaxis episodes. The cold urticaria activity score is a patient-reported outcome measure used for daily assessment of disease activity consisting of 4 items. The Urticaria Control Test, UCT, which you well know, is a PROM used to assess disease control in all types of chronic urticaria with a target score of 12 or more. Some patients may require minimal therapy if they can avoid cold exposure, but trigger avoidance is often insufficient and pharmacological therapy is usually necessary. First-line treatment for cold urticaria includes second-generation H1 antihistamines such as desloratadine, bilastine, and rupatadine, which have shown efficacy in randomized trials and case reports. These can be increased up to 4 times the standard dose, as with other types of chronic urticaria. Omalizumab, though not licensed for cold urticaria, has demonstrated efficacy in randomized trials and case reports, and it may be used for patients with inadequate control on high-dose antihistamine. Some individuals may only need omalizumab during the cold months. In severe cases, cyclosporine may be considered, but evidence is only limited to case reports. Several studies suggest that cold desensitization can effectively lower the critical temperature threshold and reduce cold-induced symptoms. However, this method involves gradual exposure to cold showers or bath, and it needs to be done under supervision. But it is rarely used in routine clinical practice due to the risk of systemic reactions and then the need for daily exposure to maintain its effects. Several emerging therapies are under investigation in cold urticaria, including targeted biologics and small molecule inhibitors. These novel drugs specifically target mediators, receptors, or signaling pathways involved in the activation or inhibition of mast cells and other immune cells. Examples of such drugs include an X2 receptor antagonist named EP262, and then an IgE trap protein targeting serum-free IgE named YH35324, and then the BTK inhibitor remibrutinib, and the monoclonal antibody barzolvolimab targeting the KIT receptor, and dupilumab, which targets interleukin-4 and 13. The efficacy of emerging therapies will hopefully shed light on the cellular and molecular mechanisms underlying the pathogenesis of cold urticaria. And thank you so much for your attention.
Thank you. Thank you. So that was a very nice talk. So thanks a lot, Mocha. So now I invite our final speaker, Dr. Hanna. She will be discussing about the differential diagnosis of cold urticaria. Thank you.
So thank you very much for the kind invitation, and I'm very happy to be part of this webinar and to speak about this very interesting and important topic today. So the main differential diagnosis of cold urticaria, and Angèle already told you a little bit about it, are certainly the cold-induced urticarial autoinflammatory symptoms. And until now, there are 5 different diseases known. So you see here CAPS, FCAS2, FCAS3, FACAS, and plate patients. And all those patients can present with generalized wheals or erythematous papules and also plaques after cold exposure. Another very important differential diagnosis of cold urticaria, so classical cold urticaria, is cryoglobulinemic vasculitis. So in this disorder, the presence of cryoglobulins in the blood can lead to vasculitis and can present with wheal-like symptoms after cold exposure. Mastocytosis, and I think most of you know this disorder, it's a rare condition with abnormal increase in mast cells. In mastocytosis, cold can be a trigger for patients and can lead to whealing of the skin. Chilblain lupus erythematosus, this is a very rare form of cutaneous lupus erythematosus, and it's an autoimmune disorder. And those patients can present with those painful red, bluish red, or purplish discoloration of the skin. They can also present with wheal-like lesions, plaques, and also nodules. And this is happening at skin sites which are exposed to cold, and therefore often fingers and toes are affected. And another important differential diagnosis of cold urticaria is cold panniculitis. So in this disorder, there is an inflammation, cold-induced inflammation of the subcutaneous fat layers due to cold exposure. And this typically manifests as red, more harder, tender bumps, but also plaque-like lesions on exposed skin areas like the cheeks and chin, especially in infants. So here is another detailed overview of the characteristic of the cold-induced urticaria autoinflammatory syndromes. So you see here CAPS, Angèle told you a lot about it, but there are also familial cold autoinflammatory syndrome 2, 3, and the factor 12 associated cold autoinflammatory syndrome, and plate, PLC, gamma-2 associated antibody deficiency and immune dysregulation compared to cold urticaria. And you see here there are affected genes, so the NLRP3 gene you all know now, but there are also other genes like the NLRP12, NLRC4, factor 12, or PLC gamma-2, which can be affected in patients with autoinflammatory diseases with cold-induced wheals. And all those genes encode for proteins which are important in inflammatory cascades in inflammasomes for NLRP3, NLRP12, and NLRC4. Factor 12, you all know it from the bradykinin pathway, and PLC gamma-2 is also part of an important signaling pathway in the cells. So all those disorders show an autosomal dominant inheritance. So many patients present with symptoms at birth, early childhood. And as Angèle also told you, the cold provocation test is negative in those disorders. And this is a clinical hint which can show you that which can lead you in the direction of autoinflammatory diseases. So in those patients, cold is a trigger factor, not only for the skin symptoms, also for the systemic symptoms, which can occur in many patients. So they report fever, chills, musculoskeletal symptoms, arthralgia, myalgia. And they have the skin symptoms accompanied by most often burning and pain and less pruritus compared to cold urticaria. And interestingly, in plague patients also report pruritus, and it also has been shown that mast cells are also involved in this disorder. So very interesting. And including to the cold-induced skin symptoms in plague, patients also present granulomatous skin lesions. So again, CAPS, I think it's very important to mention this disorder. It's a prototype autoinflammatory disease, and you've already heard this. So there is a clinical spectrum. There are patients with a very mild phenotype. So there can also be patients only presenting with atypical cold urticaria, and this can be underlying familial cold urticaria. So be aware of this and have a deeper look in those patients with atypical forms of cold urticaria. But it is a spectrum, and there are also those cases which very severe clinical symptoms and also a very early onset of disease. And so it's very important to know about this disorder, especially regarding the severity of the symptoms, and also to know how to diagnose and how to treat those patients. So I told you NLRP3, this gene is the one which shows a gain-of-function mutation in cryopyrin-associated periodic syndrome. And this gain-of-function mutation leads to an overactivation of this NLRP3 inflammasome. It's a multi-protein complex consisting of ASC and pro-caspase. And caspase-1 then cleaves the pro-mediators into IL-1 beta and IL-18. And those are the most important cytokines in the disorder, which are responsible for the clinical symptoms at the skin, but also in the at the systemic symptoms. So there is a very a low prevalence of the disorder. So 2.7 to 5.5 per million are estimated, and there's also a worldwide variance of the distribution of CAP subtypes. So in North America, FCAS is more frequent. So have an eye on that. And in Europe, there is Muckle-Wells syndrome, which is more frequent, and those patients, they often have hearing loss. And so there are many different variants reported. Over 100 pathogenic and probably pathogenic mutation variants reported in the InFevers database. This is a really nice database to which you all can have access, and you can check if you have a variant and you are unclear. So it's a really nice tool, so use it. And there are also variants of unclear significance, laser penetrance, and somatic mutation described, which Angèle has already mentioned. And it's important to know again that the clinical diagnosis of CAPS can be made also if you have no gene variant. And this is very important because then you have the possibility to treat those patients correctly. So IL-1 blockade is nicely working in those patients. Anakinra, IL-1 receptor antagonist, and canakinumab, IL-1 beta inhibit monoclonal antibody against IL-1 beta. So it's very important to know that there is targeted treatment, and this is also licensed for those patients. In addition, I would like to tell you a little bit more about cryoglobulinemic vasculitis, which is another important differential diagnosis of cold urticaria. So this is again a rare disease with a disease onset in the higher ages of life with a female predominance, and the disease trigger in those patients is ambient temperature below 37 degrees. And in the skin of those patients, you see leukocytoclastic vasculitis. The disease is caused by hepatitis C or B infections, can be linked to autoimmune diseases or B-cell lymphoproliferative disorders. And here you can see a nice overview of the clinical presentation of cryoglobulinemia syndrome. And you see, due to the hyperviscosity of the blood, there can be systemic symptoms in the patient, but also internal organs such as kidneys can be affected. The peripheral nervous system can be affected, and the musculoskeletal symptoms are also present in those patients. And very important, the skin is affected. So you see infiltrated purpura, livedo reticularis, nodules, bullae, cold urticaria are symptoms which can manifest at the skin. And cryoglobulins are immunoglobulins that precipitate at temperatures lower than 37 degrees. And there are those type 1 cryoglobulins. These are monoclonal IgMs, and they are caused by B-cell lymphoproliferative disorders. But there are also type 2 and type 3 cryoglobulins. Mixed cryoglobulinemia is it called, because they are monoclonal IgM and polyclonal IgG, or polyclonal IgM and polyclonal IgG are mixed in those patients, and this is often due to chronic infection, as I've already mentioned, hepatitis C, but also B-cell lymphoproliferative diseases, autoimmune diseases can be associated with those types. And especially in type 2 and type 3 cryoglobulinemia, precipitation of those immunoglobulins lead to formation of immune complexes and small vessel vasculitis and complement deposition. And this again leads to recruitment of inflammatory cells, production of pro-inflammatory cytokines. And this inflammation is then, of course, responsible for the characteristic skin symptoms in those patients. So very interestingly, there's also a case report of a TEMP test positive cold urticaria patient described, in which cryoglobulins of type 1 have been detected in association with a monoclonal B-cell lymphocytosis. And in this patient with no typical cold urticaria, there was a treatment with rituximab, and this was very successful in this patient. So this was one case report, of course, but if you have a look at all published cases regarding this topic, and Mojca was involved in this great analysis, you can see, so this is a good great systematic review done. So 14 relevant studies were here included. More than 1,000 patients were analyzed. And you see in those classic cold urticaria patients, there's only 3% showing elevated levels of cryoglobulins, 1% elevated levels of cryofibrinogens, and 0.7% elevated levels of cold agglutinins. And as Mojca already told you regarding the diagnostics in classical cold urticaria, so this is no guideline recommended testing in cold urticaria. Yeah. So at the end of my presentation, I would like to highlight that there are, of course, diagnostic procedures to rule out or to confirm differential diagnosis of cold urticaria. And I think the standard diagnostics are quite clear. So Mojca really guided us through what to do. And so in the guidelines is also everything very well described. So you can read it in our international urticaria guideline. But in cases of cold-induced urticaria autoinflammatory syndromes, just please think of doing differential blood, seeing markers of inflammation, which are elevated in those patients, and please perform the genetics. You now all know the genes by heart, so you can do the testing. And this is the InfeVAS database. You can also access and have a look at it. It's very interesting to see the variants which are reported in autoinflammatory diseases. And in case, of course, of cryoglobulinemia or cryoglobulinic vasculitis, be sure to rule out underlying diseases. Of course, it's very important to exclude hematological disorders, to assess, of course, cryoglobulins. And this is not so easy. So I failed often in this and had to call the patients again to do it again, because you really have to keep the blood warm. And so sometimes the way to the lab is longer than it is kept warm. So be careful with this diagnostics. And of course, you can do skin biopsy and see the leukocytoclastic vasculitis in cases suspicious for cryoglobulinic vasculitis and having cryoglobulins. And for mastocytosis, I think everyone knows you have the tryptase, you have also the KIT D816V mutation, which you can assess in the peripheral blood, but also in the bone marrow. And for Schillblane lupus erythematosus, the diagnostic is not so easy. So you can do biopsy, you can see the interface dermatitis, and you can also see signs in the immunofluorescence, such as immunoglobulins or complement, which are deposited in the skin. But with the ANA t-test, it's not so easy. Many patients with children lupus erythematosus are not ANA positive, but keep in mind that there is also in 20% of patients with children lupus an association with systemic lupus erythematosus. So in those patients, of course, you have to go deeper. And yeah, the last the differential was cold panniculitis. So of course you could do a biopsy, but here it's very important to ask for cold exposure. Ask your patients whether maybe often children eat a lot of ice cream who are reported to have cold panniculitis. So ask for those trigger factors. Yeah, so I'm at the end of my presentation, and thank you very much for your attention. And of course, I think we're all happy to answer questions.
Thank you, Hanna, for that very clear presentation. So thank you to all our speakers. So now we come to the end, and there are a few questions which I think I will direct to you. So our first question is by Dr. Ulkar. So she says that a patient with recurrent laryngeal edema claims her edema started right after taking cold food or beverages. Interestingly, she never experienced any urticarial rash. So there was no skin symptoms. So she just complains that there was this laryngeal edema after taking cold food or beverages. She is 70 years old. Her C1 inhibitor level and C1q levels are in normal range. And her edema is partially responsive to treatments with antihistamine and systemic steroids. And also epinephrine was given. So in this case, what do you think is the question? What do you think is the situation is? It's like she is having this laryngeal edema due to cold induced. So anybody can take it.
I can begin, but Anna, if you have another comment, I think it's possibly an atypical cold urticaria, and in your patient, it's necessary to perform control stimulation test, because maybe you have a positive ice cube or temp test, and it's a typical cold urticaria, but it's not so classical. I have never seen a patient with only angioedema because it's very rare to have angioedema, laryngeal angioedema with cold food or cold beverage, but I have never seen with only this symptom.
Okay. Hanna, you want to add anything, or?
Yeah, I think so there's the comment that partially responsive to traditional treatment with antihistamines. So
Yes.
for me, this maybe hints to a mast cell mediated disease, and so could also be an autoallergy mechanism. So if the patient is uncontrolled with fourfold antihistamines, and we classify this as like chronic spontaneous urticaria in the case of angioedema, then maybe we could give omalizumab a try, but of course should be licensed and everything.
But it can be a mast cell mediated disease, so that's the take home message. Fine. So now there is this next question from Dr. Salma. She says that is there any documented experience of desensitization of cold induced urticaria? Like Mojca mentioned about desensitization, but she also said that it's something which should not be done very frequently. It's very risky. But are there any documented evidences of desensitization in cold urticaria?
Yes, I think so, but I have not the reference in my mind, but I think it's a German team who perform cold bath with decreased temperature very progressively in very few patients, I think 5 or less than 10 patients. But there is a very old publication about that.
So there is some very limited documentation.
And there is other publication. We report that in a cold country you have less crisis of cold urticaria that in the temperate countries, and this publication do the hypothesis that there is a desensitization by the cold environment too, not only the cold bath.
Okay, thank you. And now there's this question, very interesting, that why is it that only cold urticaria patients can develop anaphylaxis and not any other variant? So is there any answer to that? That why is it that only cold urticaria can develop anaphylaxis and none of the other forms? So what do you think?
Hanna, maybe you have an idea. I think it's not a real anaphylaxis. In my opinion, it's a vasoplesic shock because you have all the body in cold water, for example, on cold environment. And you have the same process during cholinergic urticaria, for example. Some patients, very rare, but have hypotension and malaise. I have ever seen this type of patient. I've never seen this type of anaphylaxis during spontaneous chronic urticaria without inducible urticaria, but I think it's possibly in cholinergic urticaria. I don't know, Hanna, what is your opinion?
Yeah, so I have the same experience. But of course, it's a good question because, in heat urticaria or pressure urticaria, so basically it's a good question, and I think it leads to more research. But yeah, Angèle, I agree with you.
Yes, but maybe in the pressure urticaria, it's very localized. You have no situation of all your body, it's on the pressure, and I think it's because it's a physical cholinergic and cold urticaria. It's a physical, it's environmental, and all the body is exposed, in my opinion.
Okay, so here is just a rejoinder which is coming, that she says that anaphylaxis has been described in other forms of inducible urticaria also, like cholinergic urticaria, aquagenic urticaria, heat urticaria. I think this is correct because cholinergic urticaria may actually result in anaphylaxis. So I think, okay. So now there is one question from my side, that this you described about the typical and atypical forms of cold urticaria. So do they have any prognostic significance, like we have for the endotypes of CSU, that maybe this subset of patients will respond better to therapy, or any other importance therapeutically or prognostically, the typical versus atypical cold urticaria?
It's difficult to respond to this question because when it's typical, it's you are sure of the diagnosis and you know the disease. It's called urticaria. When it's atypical, in my opinion, in my experience, you choose. You check everything, you do other exam, and but now if there is no anaphylactic shock, there is not laryngeal or pharyngeal edema, angioedema, the treatment and of the patient are the same, and in clinical practice there is no difference.
Okay, thank you. And so just before we end up, we are already at the end. So there is this one question which I also agree that, cold urticaria is very rare in tropical countries, like from where I am. So do you have any tips? You can go one by one, that how to identify cold urticaria, because it's so rare in this part of the world. So how to suspect cold urticaria, just from the history and family history? What do you? So are there any, how to just identify cold urticaria?
Do you mean typical cold urticaria, or so?
There is a typical, no, typical
Okay,
cold urticaria.
yeah.
Yes.
Yeah, I think we would start with easy questions like just what's happening if you open your fridge, if you take something out, what's happening? Or, you also have in the warmer countries have a lot of climatization, so you have the air conditioning, and so then you can ask what's happening if you go from a hot room, so hot outside into a cool room. So I would start with easy questions, which could lead you to this diagnosis.
Okay. Thank you so much. So I think we are almost at the end. I'll just share the concluding part of the presentation. So I thank all our speakers, and Mojca is of course not here live, but she did a fabulous presentation. And thank you, Angèle, and thank you, Hanna, for explaining this difficult disease in such simple words. I'd like to thank our viewers who have tuned in and who have stayed throughout the program for some really interesting questions. Now, last, I'd like to again remind you that please complete this feedback form in order to receive the CME point. The QR code is there. I think I'll wait for 2 seconds. So please scan the QR code and complete the feedback form to get your CME points. Okay, so stay connected with us. We have newsletters. We have multiple programs, LevelUp, Journal Club, a lot of different types of programs. So stay tuned to us. Stay tuned to our newsletters. And so after we finish this fantastic webinar, I'd like to request you to register for our next UCARE webinar, which is on 11th of September. And this concerns cholinergic urticaria, which is again another very rare but important subtype of inducible urticaria. And Jason, our very good colleague, will be moderating this. We have speakers from Japan, Sabine from Austria, Mishiro Hide from Japan. So that will be a very engaging webinar. So I request all of you to register for this. So here is again the QR code. I'll keep it for 2 seconds so you can scan it. This will take you directly to the registration. Okay, thank you. So thank you from my end, and I'd like to thank our sponsor Novartis for this. So thank you very much for joining in for this wonderful webinar. And yes, there is one question. I think, will you be able to share the recording link? I think this webinar is being recorded and it will be posted on the UCARE site. So thank you very much. Take care. Goodbye. Thank you.